We're going to jump right in to Dr. Balan's presentation. So Dr. Balan, the floor is yours.
Let's go back up to the top of the talk there. If you could go back to the first slide for me, please. Are we having some technical difficulties?
Yeah.
Well, that's whole talk in reverse. So there you go.
I got it.
Yeah, and if you could go into presentation mode.
Here, let me see, hit the presentation button. There you go.
There we go. Thanks for having me this morning, Joe. We're going to talk about patient selection for VA ECMO. A couple of disclosures to start out. What is the purpose of ECMO? It's temporary support for heart and/or lung function for a reversible disease process in order to bridge the patient to something better. It is not a treatment in and of itself, but it creates an environment to allow us to treat the underlying problem. The goal of this therapy is oxygen delivery. It's all about getting blood, i.e. the oxygen carrying capacity of hemoglobin, circulating, getting an oxygen saturation that is up there at 100%, and using flow, cardiac output, and flow from the circuit to deliver that oxygen to the patient. What are the indications for VA ECMO? There are a number of them, and these indications are growing and broadening as we continue to learn. Obviously, failure to wean from cardiopulmonary bypass has traditionally been a reason to place a patient on ECMO. More often now, what I do, I'm an interventional cardiologist, it's the cath lab crashes, the failed intra-aortic balloon pump. It's not enough support for the patient. I'll show you a case of that later in this presentation. ECPR, that is something that is becoming more and more common. Cardiac arrest is something in this country that is very common. There are probably 180,000 cardiac arrests a year in the United States. On average, survival is about 7 to 10%. With intervention, we can increase that number, and ECMO may play a very central role in that, and we'll talk about that as we go along. Many of the ischemic situations are important to provide substantial hemodynamic support. Valvular cardiomyopathies can also be situations. Joe mentioned a recent case of mine with a ridiculous gradient across the aortic valve, cardiogenic shock from the valvular cardiomyopathy effectively. Right heart failure, acute pulmonary emboli, massive pulmonary emboli, we've used ECMO under those circumstances to bail patients out. Chronic pulmonary hypertension using ECMO as a bridge to transplant for profound right heart failure is certainly a valid option. Intractable arrhythmias, VT storms, ECMO can be used to bail these patients out. Even septic shock, profound vasodilatory shock, until you can correct the underlying cause, the underlying infectious cause, ECMO can provide the necessary support for your patients. Sudden cardiac death, as I mentioned, is a big part of what I do, and ECMO certainly can help under these circumstances. In terms of what you're trying to accomplish with ECMO, rapidly getting the patient on hemodynamic support allows you the platform from which to stabilize and thereby find the underlying cause and correct the underlying cause of the shock state. Conversion to a permanently implanted ventricular assist device can be done electively once you have that stability. In terms of providing cardiac support, if you're providing cardiac support alone, sometimes you've got to think about the health of the lungs. Many of these patients, as a result of the cardiac dysfunction, their lungs are full of fluid and they're not functioning well. You've got to think about providing heart-lung support, and sometimes that means going to VAV, and we'll talk about who's a candidate for that in just a little bit. So your goals with ECMO support, particularly in the setting of cardiac arrest and sudden hemodynamic collapse, is to protect the viscera, maximize oxygen delivery, rest the heart, come off of all of the inotropes, which are in many ways cardiotoxic agents, the dopamines, the epinephrines. Beating the heart with inotropes sometimes worsens, and there is data coming out to this effect, that actually worsens the long-term outcomes for the patients. Obviously, improving CNS function or preserving CNS function in the setting of cardiac arrest, hypothermia is a very valuable tool here. And of course, that can be done directly through the ECMO circuit. In terms of the adequacy of your support, what you want to look at are some of the things that Kimberly talked about earlier, bringing down the lactate level. Is there a urine output? Maintaining a mean arterial pressure, mixed venous oxygen saturations. And we'll talk about the needs for lung support as we go along. The idea here with ECMO is to provide a bridge to both diagnosis and treatment of the underlying cause. Your goal is to have a nice, beautiful bridge to somewhere, not put the patient on a bridge to nowhere. Now, here are some of the situations where ECMO can provide that bridge to a better place. Primary arrhythmias, as I mentioned, situations such as VT storm and many of your non-ischemic cardiomyopathies. Once that left ventricular end diastolic pressure reaches a certain threshold, the myocytes are thrown into a situation where they cannot repolarize and you trip off arrhythmias. You can use antiarrhythmic medications, but if you can't bail them out with your lidocaine drips and amio drips, you really need to go to hemodynamic support because you're going to lose the rest of the body while you're trying to control the arrhythmia. Massive PE, as I mentioned, is another situation that can cause complete hemodynamic collapse. The use of ECMO under those circumstances allows you to quickly and rapidly support the patient while you choose a treatment strategy. And as we know now, the number of treatment strategies are exploding. Catheter-directed therapies, surgical embolectomy are all possibilities here. Ischemic heart disease, a lot of what I do, patients who present with ST elevation MIs complicated by VFib, if they are in profound states of death and shock, oftentimes ECMO provides you that opportunity to revascularize percutaneously or otherwise so that you can reestablish life. Structural heart disease, another big area of interest for me, particularly aortic valve disease. Absent support, sometimes it is difficult to have the time to get these patients to a definitive therapy, whether that is surgical, valve replacement, or percutaneous valve replacement. The cardiomyopathy space, also very important. The number of non-ischemic cardiomyopathies that we see these days are exponentially increasing. Some of these are acute myocarditis. These patients are very sick. They just need time to recover. And there are treatments for this. So if you bridge them to recovery with ECMO, you have a substantial chance of saving some of these patients. So thinking about the indications for cardiac support with ECMO, failure to wean from cardiopulmonary bypass, cardiomyopathies such as acute myocarditis, cardiac arrest, eCPR, cardiac failure, ECMO provides you that bridge to diagnosis, treatment, potentially recovery. And if there is not recovery, then to permanently implanted LVAD or even transplant. Other situations, massive pulmonary emboli with hemodynamic collapse, septic shock, arrhythmias, malignant arrhythmias, drug cardiotoxicity, and acute MI. Undiagnosed hemodynamic stability, and in many ways, the reason I put this in is ECMO gives you the time to figure out which of these other potential causes has resulted in this hemodynamic collapse, and thus allows you that opportunity to treat and take care of these patients. Now, so far we've talked about the reasons to put a patient on. When should you not put a patient on? When you're dealing with irreversible or untreatable heart-lung conditions, there's no point in putting a patient on that bridge to nowhere. Severe vascular insufficiency, oftentimes patients with advanced vasculopathies are not going to be candidates for permanently implanted VADs or transplant, and therefore you should not put them on temporary support. Obviously, patients with major intracranial hemorrhage, it's an absolute contraindication. Severe or progressive chronic lung injury, these end-stage COPD patients, There's no bailout for many of these patients. Even lung transplant is not an option for many of them. So don't put a patient on who does not have an exit strategy. Irreversible processes such as malignancies and end-stage lupus. And just as an aside, in many ways, I find lupus to be the worst disease possible. It affects every organ system, and I've seen too many young people pass away from this condition. And it's a great example of the kinds of irreversible processes that we cannot bridge with a technology like ECMO. Now, what are the goals of ECMO cannulation? You want to maximally drain the venous side and provide unobstructed flow on the aortic side without creating distal ischemia, particularly to the leg. Most often I use the leg. Having some technical issues here with moving this forward. You want to minimize the risk of infection to the patient, maximize the ability of the patient to recover, and individualize the treatment for each patient. You need to have a well thought out plan to accomplish this. There are many ways you can put a patient on VA support. Most often in the crash situation, that's going to mean femoral VA support, access the femoral vein, femoral artery, flow from vein through the circuit back to the artery. In terms of your sites, most often someone like me is working in the cath lab from the femoral. Typically when you do this, you've got to be careful of peripheral arterial disease. I make it standard at this point to place an antegrade distal perfusion catheter for all of these patients. You access the superficial femoral artery on the side with the cannula, point that sheath downwards and hook to the side arm so that you create a circuit to perfuse that leg. Having an ischemic leg, a dying leg, saving the patient and losing the leg is not a reasonable option for these patients. You definitely want to save the whole patient. Now, some special circumstances, I mentioned the issues of lungs not functioning, venting the patients. One of the concepts here in cardiac support with ECMO is you are going to see a massive increase in left ventricular end diastolic volume and therefore pressure. What you're looking at here are the pressure volume loops from the left ventricle. When you place a patient on ECMO, as I mentioned, you are going to increase the left ventricular end diastolic volume as well as pressure. That shifts that entire pressure volume loop over to the right and produces basically a large increase in preload, a large increase in afterload with a loss of contractility. Essentially, what you're doing is the opposite of everything you want to do to help a heart. Of course, that's buying you the time to help that heart, but essentially you're putting the heart in a really bad place. Venting that ventricle allows you to decompress that ventricle and therefore not harm it in the long run. And there are a number of ways that you can do this. It can be done surgically. The LV can be vented. From a percutaneous standpoint, frequently we use the Impella device that can allow you to unload that left ventricular end diastolic volume and therefore pressure, and thus move that pressure volume loop back down and to the left so as to unload the ventricle. Now, keep in mind, VA ECMO, it's great for cardiac support. However, if you've got lungs that are not functioning, you're going to run into serious problems. Specifically, if you've got lungs that are not capable of oxygenating or ventilating, you're going to get blue venous blood that's going to circulate from the right side of the heart back to the LV through those non-functioning lungs. And if that heart is ejecting, what it's ejecting is blue blood to the arch vessels. And therefore, what the brain is going to see is deoxygenated blood. You're going to end up with what's called differential hypoxemia, informally sometimes called north-south syndrome or Harlequin syndrome. The way to address that, one way to address that, is to simply go to VA ECMO, wire that arterial cannula, and return oxygenated blood to the right side so that what the heart is ejecting is in fact oxygenated blood. Now, the tools needed for rapid percutaneous placement of patients on ECMO, fluoroscopy, ultrasound, echo, skills with catheters and guide wires. We were just talking about the importance of being facile with catheters and guide wires. It is absolutely essential in the ECMO space that surgeons and interventionalists have these tools in their toolbox. In terms of goals from a flow standpoint, for an adult, you want to see 50 to 75 milliliters per minute per kilogram. Your goal, as we said, is max oxygenation using both the pump and any native flow that the heart is providing. Some pearls of wisdom that my mentors taught me: in an emergency, move quickly. You can make adjustments later. With your arterial return cannula, it's better to err on the side of being too far in. The last thing you want is for that cannula to come out. I've seen that happen, and it's truly a bloody mess. On the venous side, go big. Okay, most people's veins are distendable, and you can put a 24 French cannula in there. Your goal is to get maximum drainage on the right side. That will maximize your flow in the long run. You can cannulate quickly under local anesthesia. Frequently, when we're doing high-risk procedures, we keep sheaths on reserve just in case we need to go on. I always have one extra 5 French venous sheath during a MAC anesthesia at TAVR, whereby if I have to go on, I have that access in place. And as I said, use the right tools. Frequently, these are crashes happening out in the field, and I'll show you a picture of that in a moment. However, if you have the assistance of fluoroscopy and ultrasound, do these things with eyes, do it with guidance. I'll make a quick segue into eCPR here because this is an important subset of what we'll be using ECMO for in the setting of cardiac support. This is an area of large research interest for me, and as I mentioned, cardiac arrest is ridiculously common, and we see a lot of young people dying from this. Use of ECMO in this space can certainly improve survival. You can use VA ECMO for ongoing CPR ACLS. It is best to do it in patients who have a reasonable chance of survival. That is, patients who suffer a witnessed arrest, have the opportunity to receive immediate CPR.
You want to point it towards the, there you go.
CPR that's short in duration, CPR of less than 30 minutes. It is oftentimes best to use it in patients who have an initial rhythm that is shockable, VT or VF. Your outcomes are not as good when you have PEA or asystole. Younger patients tend to do better than older patients. Basically, you want to take those patients who have a reasonable chance of survival because they have a reversible or treatable cause for their cardiac arrest. You need rapid percutaneous access and aggressive evaluation and treatment for these patients. Is there data for doing this? Absolutely. This is from a study done by the group at the University of Minnesota, where they took about 145 consecutive out-of-hospital cardiac arrests with refractory VF, put them all on percutaneous ECMO in the cath lab, and then revascularized the coronaries. They saw a survival rate of about 45% with this. They compared that to a historically propensity-matched cohort where patients were treated only with ACLS. The survival there was 15%. So that's a massive improvement in survival from 15% to 45% with basically eCPR and immediate revascularization. So there is a place for this technology in the cardiac arrest space. This is a picture, as I mentioned. We're going to be doing a lot more of this, I think. This is from the floor of the Louvre in France. This is from late 2017. The Europeans are way ahead of us in this regard. It's a portable ECMO team cannulating a cardiac arrest patient on the floor of the Louvre and then transporting to one of their level 1 centers. In terms of eCPR management, your goals are to drain the heart as quickly as possible, treat any malignant arrhythmias, eliminate those toxic catecholamines, the dopamines, the epis, and get them to the cath lab for urgent revascularization. As you do this, you need to protect the brain, cool as quickly as you can, and then protect the viscera by flowing at high rates, high flow rates, protect the liver, protect the kidneys, protect all the other vital organs. From a brain standpoint, Hypothermia has shown significant advantages in terms of neurologic recovery. And then from the standpoint of saving the body, as we mentioned, maximize flow, bring that lactate level down, watch your liver function numbers, hopefully get those down as well. Use CRRT, as Kimberly elegantly described, to support not only the kidneys themselves, but the overall electrolyte balance for the patients and acid-base status for the patients. Get these patients fed quickly, as we were talking about. Having oncotic pressure is very, very important, and keeping the GI tract alive and going with enteral feeds is very, very important. From the standpoint of the rest of the body, apart from vital organs, the periphery, the extremities, protect those extremities. There's no point in saving a life. There may be a point to it, saving a life at the expense of the limb, but if you can save the whole patient, go ahead and save the whole patient. And if that means putting in that antegrade catheter, which I think should be uniform, even if you've got giant vessels and you think you can flow around that cannula, do it anyway. Once these patients get into states of hemodynamic compromise, oftentimes even big vessels clamp down. They clamp down around that cannula and you lose flow. Therefore, providing that flow through the circuit with an antegrade perfusion catheter is vital. Oops, went ahead of me a second there. Let's talk about a couple of cases to illustrate some of the concepts that we've just talked about. This is a TAVR patient that we treated just last week, actually. Young woman, 64 years old, and this is how we present patients in our valvular and structural heart disease conference. Multiple comorbidities. Basically, she suffered from myasthenia gravis with myasthenia crisis and morbid obesity. This lady could hardly move as a result of her myasthenia. Therefore, the surgeons deemed her at least intermediate, if not higher risk for an open surgical AVR. She had severe aortic stenosis, mean gradients that were measured by echo at about 50 plus millimeters of mercury, no significant coronary disease, and reasonable but highly calcified access. And there was some degree of peripheral disease. You can see those external iliacs on the left were relatively small. The plan for her was treatment with a 23 millimeter balloon expandable prosthesis. And as we went ahead with that intervention, we did run into some difficulties. Here you see the original aortogram at the start of the procedure. She has clean coronaries. However, you notice the right has a particularly high anterior takeoff, the right coronary artery there. The valve turned out to be quite a bit tighter than we anticipated. Even a simple valvuloplasty balloon, a 20 millimeter valvuloplasty balloon, would not cross. So we actually took a 10 by 40 peripheral balloon here and put that across the valve to create an initial valvuloplasty to serially dilate up to get our valve across. Immediately after this valvuloplasty, the patient fibrillated. One defibrillation, we got her back, and she was maintaining her pressure at that point. We were then able to dilate with a larger valvuloplasty balloon, and then ultimately bring our valve across and smoothly deploy the balloon expandable 23 millimeter prosthesis. At this point, we again had VF, and when we take our aortogram, something's missing.
Yeah.
That right coronary artery doesn't appear to be there at this point. The EKG is showing us ST elevations, and now we're getting hypotension as well, 80s over 40s. She's looking truly shocky to us. And as you can see, something has gone down that proximal right coronary artery. There is clearly a filling defect there. We did look at it by intravascular ultrasound. My suspicion is calcium from the valve itself embolized down the coronary artery. We were able to engage the artery, wire it, balloon, and stent the artery, which did take some time, but we did it all on ECMO support. Given the hemodynamics instability, the VF arrest requiring defibrillation, the low mean arterial pressures, we did all of this on VA support, 17 French arterial cannula, 23 French venous cannula. We had the stability to go ahead and do this intervention. It was not easy to engage this artery with the valve right there and the high anterior takeoff. However, VA ECMO provided us that opportunity to bail this artery out. Without that support, there would have been ongoing hemodynamic crisis. Ultimately, here you see the final shot of the right. We were able to repair that. Excellent valvular function. We left her on VA support for 2 to 3 days as she recovered from the shock state. She came off VA ECMO 2.5 days after initiation, bridged out from there on a balloon pump, which is now out. The patient is now extubated off of all hemodynamic support, off of all pressors, is now doing physical therapy. Her EF is fully preserved. Second case, young gentleman, 51 years old, some risk factors, particularly diabetes, comes in with tombstones, high anterolateral ST elevation MI. There's the initial angiogram. You can see the LAD is cut off, and you can see there's a severe lesion in the proximal circumflex as well. And most likely that was not just a bystanding chronic lesion. It's actually somewhat hazy in most of these views. You see it in the LAO view here, that there truly is a hazy stenosis in that body of the circ. Of course, now I started with a balloon pump here. This was very early in my career. This is a case from 2013. And that shakiness that you see in the image is CPR. We bail out the LAD as quickly as we can. But now notice, we've got the LAD back, we've lost the circ. So then you get more CPR as we're trying to bail out the circ here. And we get the circ back quickly, but you can see this is a very unhappy heart. We get him on VA ECMO, and that gives us the time to recover this patient. We get him up to the ICU, 4 days on support. He comes off, transitions beautifully. Ultimately, 5 years later now, 6 years later now, this gentleman still follows with me in clinic, completely preserved ejection fraction. Without the ECMO support, we would have been lost in a tunnel of VF at the end of this case. Even though we'd gotten the coronaries back, ECMO gave us the time to bail him out of the recurrent VF VT that we had at the end of the case. So with that said, I just want to acknowledge my mentors. I want to thank Mike Hines, who taught me most of what I know about ECMO, as well as the Extracorporeal Life Support Organization. Thank you.
Excellent talk. Very, very good. So you brought up a lot of very good points, and again, I'm going to go off script, and we're just going to open this up and have a discussion before I do my presentation. Mine is on cannulation strategies, and I copy a lot of things that you were talking about. Maybe talk a little more about exotic cannulations, but I'm really wanting to focus on your point, and I'm bringing this up because I was told this 3 weeks ago by an intensive care medicine doctor. ECMO has never saved anyone, and he doesn't think it should be done for anybody. How would you reply to that?
I vehemently disagree. I have a clinic full of patients that are survivors from cardiac arrest that I've bailed out with ECMO. Mm-hmm. That we as a team have bailed out with ECMO. It gives you, as I mentioned in one of the early slides, it is not a therapy in and of itself. It is a support that one uses to provide the appropriate therapy, and even gives you the time to make the diagnosis. Okay. In that TAVR case that I just showed, initially she VFs, we have no idea what's going on. We don't know why this patient is fibrillating before us. Why is she hypotensive? Why is she shocky? It took some time we did a ventriculogram, we did an aortogram, we engaged both the coronaries. All of this is taking time, and the patient is in profound shock. Putting the patient on support gives you the time to figure out why this patient is crashing and then go about fixing it. As I said, this was a very high anterior takeoff. I remember when I did the diagnostic cath for this patient, I had trouble engaging that right. Now with a valve in there in shock, I have to re-engage that thing with a guide. I need the time to do that. And ECMO provides me that time and that support, keeps the patient going until I can fix the problem that's creating the hemodynamic collapse.
And I think you brought up the key, the takeaway message that I'm trying to get out there. And that is patient selection really matters. Right. So I think that what happens, and you've seen this in your career, they put an already deceased patient on ECMO and then wonder why the outcome isn't any better.
Right.
And that's the issue. And with this recent, we had Matt Warhoover was online last night, and that case you're talking about, that one that you just did, but that was Brianna from last night that was the perfusionist, right?
Correct.
That was Brianna.
It was a team effort, exactly. She did a great job.
Good. Brianna, if you're listening, shout out from Dr. Balan, okay? Great job on that. But he was on, and of course, there's this big problem right now with ECMO reimbursement. I don't think it's going to stay like that. There's no way you could justify $8,000 as a reimbursement for a VA ECMO for a patient that hits your emergency room with refractory, lethal arrhythmia. But how do you discuss the reasons why that happened? That there is an abuse in the system. There is a utilization of the tool improperly, perhaps not for nefarious reasons, just as a result of a lack of education, a lack of knowledge.
In terms of appropriate patient selection, we do have to choose the right patients for this therapy. There has to be that reasonable chance of survival. Absent that, you really are on that bridge to nowhere. Okay. And particularly, that's why I went into the ECPR stuff a little bit, because that's a context where, if the patient is truly cold and dead. I once had a case, was called down to the emergency room. Gentleman was part of the cleaning crew at the Astrodome.
Oh.
Okay. He was found on a Saturday morning in the stands down. The last time he had been seen was cleaning up after a Friday night high school football game. He was probably dead for over 12 hours.
Yeah.
There's no point in doing anything for that patient. He is deceased. On the other hand, a patient like the one we saw, the last case that I mentioned, did another case recently, 49-year-old running the marathon. About mile 6, he has chest pain. He calls his wife and says, "I'm having chest pain." She tells him, "Don't call me, seek medical attention." Luckily, he's on the route of the marathon. There's medical attention all along the route. He collapses in front of the medic, gets immediate CPR. There's an AED there. AED reads VF. And as I mentioned, the chances of survival when it's VF or VT are exponentially greater, 17 times greater than when you're dealing with PEA or asystole. Okay, that's been documented. Younger age, this was a 49-year-old South Asian gentleman. Hit home for me because I'm a 49-year-old South Asian gentleman. Immediate CPR, shorter runs of CPR, as in if you're under about 30 minutes, your chances are better. That 49-year-old, unfortunately, it was about 60 minutes of CPR, but we bailed him out. Immediate hemodynamic support, revascularization, guy's fully neurologically intact. It was a long CCU run. However, fully neurologically intact and now rehabbing at TIER. So some of the factors that I outlined, younger age, witnessed arrest, immediate CPR, short runs of CPR, those are the kinds of things that favor survival. And we've actually been able to show this. We've used a Houston Fire Department database of over 15,000 cardiac arrests.
Wow.
And been able to validate these simple factors as predictors of survival. Patients who hit all of these markers have a 90% chance of surviving sudden cardiac arrest. Whereas if it's an unwitnessed arrest, no immediate CPR, asystole, they're nowhere near medical help, they're older, your chances of survival are in that 7 to 10% neighborhood. It may not be worth it. And we need to make those choices. We need to decide up front that there is not a reasonable chance of survival here. Let's not go on. On the other hand, that 49-year-old with a teenage daughter, that's the person you throw everything at because he's got a shot.
Yeah, if you're 95 years old and, regardless that you still work in your garden. And look, I've got a 99-year-old mother. We all have moms, right? I mean, and I certainly can understand the visceral, anguish of a family, but I'm going to kind of throw a hardball question at you, and it's a tough one, but it's, I think, a reality. You put the patient on ECMO. When is enough enough?
My threshold is 4 days. If I do not see a chance of reasonable
On
recovery
VA.
on VA
For
ECMO,
VA, not
okay.
VB. No.
I've had those cases, and I actually thought about putting in one of those cases just in the interest of equal time. I showed you some great saves. A lot of these that are not great saves. The data from that University of Minnesota study was 45% survival. Means the majority of these don't make it. Okay. If at 4 days you have no neurologic recovery, you've got a patient with cerebral edema and anoxic brain injury, your chances of making it out of that are slim to none. And yeah, you've got to turn it off.
Mm-hmm.
At that point, you're just flogging literally a corpse.
Mm-hmm.
It's not the right thing to do.
You know, it's not, but we've seen that happen. In my own practice, we both Kimberly and I have the same experience, and these are well-meaning physicians. But it's hard. It's very tough to say, you know, I'm going to turn this off. But, you know, and some of the patients, I mean, remarkably, I was confident they were not going to get off ECMO. Now, they got off ECMO. They didn't go home. They got off ECMO. You know, and I am torn with that. You know, who you know, elected me, you know, overseer of ECMO. You know, I mean, I just, you know, we're there as facilitators and there to provide a service. We're not there to make those kinds of decisions. But at the same time, we have to understand that there are limited resources. And if we use the resources up on an 85-year-old, again, notwithstanding they were playing golf and they were having a good life, we don't have the resources for the 49-year-old. And that's where the problem is.
We have to make difficult decisions sometimes. If we have to make those decisions up front, I'm trying to find the right sets of data on which we can make informed decisions. If we choose to go on, there is a point in time where I think we have to reevaluate. And I don't know why I've chosen 4 days, but in terms of the playing out the neurologic piece, I think that's where it comes from. By 96 hours, I have a pretty good idea of where this is headed from a neurologic standpoint.
Well, even if you're neurologically, and guys, please jump in, okay? I mean, I don't mean to monopolize. I do that a lot. I get criticized for it sometimes. Rodell, in case you're watching. You may have, the patient may be neurologically intact. They might be looking around and, you know, and you're snowing them. But their heart is never going to recover, and they're not a candidate for anything. And their kidneys are gone, but they're living off of CRRT. We can make you look great. We're good at that. But once all of that's withdrawn, there's nothing there. So you're not a candidate for transplant. So your heart is not going to recover. It's not moving. It's gone. Your kidneys are gone. Your LFTs are on the rise, but you're neurologically intact.
That's not a meaningful life. So sometimes you have to make that bridge to decision. Mm-hmm. And that's really what this is. You get to that point a few days in where you realize even if that patient's awake and there's no chance of reasonable survival and there's no exit strategy, for the heart, if there is not the opportunity for a VAD or a transplant, you have to stop.
Mm-hmm. I think you're right. It's tough. It's tough, you know, because we are, you know, we you know, we repress our emotional. Mm-hmm. It's why we're all so weird. Yeah, medical people, we're all crazy, you know, for a reason.
None of us is God. None of us can play judge, jury, or executioner here. We make the best decisions we can under the circumstances. And then we use the judgment of not just one individual, but multidisciplinary teams. And I think here, you mentioned mid-levels and so forth. I view it, we're all a team. Everyone's got to work together. Everyone's opinion is valuable. Everyone's perspective provides insight. And as we make some of these difficult decisions, it takes the heart failure specialist, the interventionalist, the surgeon, the perfusionist, the nurses, all of us have to put our heads together to really find what's right for this patient. We have to work together with the family and the patient. And I oftentimes rely on what would this patient's wishes have been under these circumstances. And I talk to spouses and children and ask, did they ever confide in you as to what they would have wanted if they were in this situation of extremis? And sometimes you do find out that, mom really wouldn't have wanted any of this.
Well, I'm going to tell everybody right now, for the record, everyone at this table, everyone in the audience, and everyone out there on the web, I don't want it. Okay. When it appears I no longer have meaningful life, John, Kimberly, pull the plug.
Yeah, very good. Myopathy is exploding the way it is.
I think it has a lot to do with the American food industry. Have you ever looked at the numbers in terms of sodium in anything that's any processed food in this country?
I'm a big sodium person,
Yeah, it's a problem. And I do think that for certain populations, the ability to handle or manage that sodium load, they don't do well with that. And as a result, end-stage hypertension, it creates extraordinary renal damage, it creates extraordinary damage for the heart. It's truly a catastrophe. And what's sad about it is, in some ways, I think we're doing it to ourselves.
Do you think that IV drug abuse is a role in as well?
I do think so. Again, another sort of self-injurious process whereby many young people we see with these kinds of self-induced cardiomyopathies as a result of a variety of toxicities.
In terms of something we were mentioning with ECMO, you were saying with Femoral ECMO, you almost invariably have LV distension. You were showing how the curve shifts to the right. We see that, and a lot of the approach is sometimes to put an Impella in, but the first approach is usually to turn up the flow in the hopes that you're draining the right atrium more.
Correct.
That doesn't always work, but it sometimes works, but you still have the paradoxic influence that you're flowing retrograde up the femoral artery directly at the aortic valve, which even if it's not regurgitant, is resistant to an already weak left ventricle that probably couldn't eject very well in the first place, which is why they're on ECMO. So do you aggressively treat the LV distension, quick to put, say, an Impella in, or...
Actually, not that often. Oftentimes, treating the underlying cause of the LV dysfunction quickly gets you back to pulsatility, allowing the native heart to unload itself.
You're talking pharmacologically, too?
Pharmacologically, yes, to some extent, but like I said, I want to avoid those high-dose inotropes. Yes, the lady with the TAVR case we mentioned, I did have her on a low-dose 2.5 dopamine, just to provide that little bit of inotropy, to provide some pulsatility to help unload that ventricle. I did not put her on an Impella, simply because I didn't want to shove anything through the freshly implanted valve that I had just placed. So it is not frequent that I have to use the Impella as a vent patient, so that you have an idea of what is that wedge pressure, which reflects that LVEDP for you. And if that is beginning to mount significantly, that's when I have that threshold
So
to
you're
go
watching
to
your wedge pressures. Okay.
Exactly. And if I'm seeing a non-pulsatile LV in the setting of rising wedge pressures, that's my threshold to go to a vent, the percutaneous.
Combined with the analysis of an echo, I would think.
Correct. But if they're pulsatile, if they're able to eject and they're showing me that they've got that shot at recovery, I'll wait. You really don't want to introduce another large bore cannula if you don't have to in these patients that are critically ill, have vascular access issues, or coagulopathic.
Well, I made this comment yesterday or last night. I think the Impella is a good tool, but I think it's like many other things, it tends to be overmarketed and overused. And I think that it has a place, just like ECMO has a place. It's like TAVR has a place. Everything has an appropriate place. Heart surgery has a place. So I think that our mission is to use it appropriately as best we know how, as best we understand what appropriate is, right? That's what I think the real goal is.
I want to talk about something. You said you had an email or text 3 weeks ago from a CCM doctor that said ECMO should never be used. And no
It
one
wasn't a
ever-
text, no, it was a face-to-face
Oh, okay.
conversation.
No,
It was a face-to-face
People have those these days.
Yeah, exactly.
But his opinion was, or his experience was, his or her, that no one gets better on ECMO. I actually heard that, my exact quote myself, just about 2 weeks ago from a clinical educator from one of the device companies that has something to do with ECMO. And she actually said, no one ever gets better on ECMO. It's just buying you time to get somewhere. Well, that's not true. I see people getting better on ECMO all the time. But the time that you're afforded is the reason why they got better. You know what I mean? That is the reason. They needed that time to experience rest, recovery, or treatment, or
Sure.
all three. So if his experience or her experience was no one's getting better on ECMO, in their particular hospital, they're putting people on way too late.
Right.
So,
Well, that's
no one
true.
is getting better because they didn't have a chance to get better
That's
in
VA
the first place.
and VV. I totally agree with you. You know, I mean, we've talked a lot about VA ECMO, which really should have been the thrust of your talk. Mine's going to be more geared towards VV, but also some exotic cannulation strategies. But even with ARDS, secondary to pneumonia or whatever it may be, if you have the patient on a ventilator for 7 days at maximum ventilatory support with peak pressures of 40, 18 of PEEP, 100% FiO2, and still and having been satting 80 to 85% for the past 7 days, come on. That the lungs are no longer recoverable. You can't do that to them and expect them to be able to get better. So the problem becomes people will argue, you put the patient on early. These are people who disagree with ECMO. You put the patient on early when you see it going that direction, they get better, transition off of ECMO, and ultimately do fine. Their argument is, you put it in too early, they would have left the hospital anyway. They would have gotten better on their own. And I have had these arguments with people multiple times, and it's just like, it's almost as bad as albumin. The albumin is 0.5. And we have zero intravascular volume left. But oh no, albumin is of no value. Just give more saline. So you give it and it's gone before it has an effectiveness of 5 minutes at best. And just liter after liter after liter. And the next thing you know, your patient's 35 liters overloaded, and they're not going to survive. Well, then no, they're not going to survive. So then they decide to put them on CRRT, and then they don't survive, and they say, look, CRRT doesn't work.
You can't have it both ways. You can't say that we put it on too late, so we never should use it, but then we put it in and it was too early, we shouldn't have used it. You have to be on one side or the other. If you believe we're putting it in too late, you're going to have an occasional time where maybe you didn't have to put it in, but you did. I mean, there's a little bit of a price to be paid for success. It's not free. So maybe 8 or 9 out of 10, you did put it in early enough and they did survive. And maybe that one, you could maybe say, but you're armchair quarterbacking. Even if you say we put it in too early and we didn't need to, you're still armchair quarterbacking. You don't know that. You must have felt something serious enough to put it in, right? So you have to be on one side of the fence or the other. I don't think you can play both sides, and then you're in no man's land. You never put it in ever.
If you're an intensivist, you can be. You could walk both sides of the fence. That's what they did. If you're an administrator, you can really straddle the fence even with razor wire and scoot along on it. They do just fine with that.